All right.
Okay.
Awesome. All right. I will do my introduction and then we'll get started. So welcome back from lunch, everybody. I'm going to dive right into introducing our final conference session, discussing refractory epilepsy and hard to control seizures. For this session, we are very lucky to have not only a wonderful speaker, Dr. Marjorie Bunch, but also a panel of individuals who have agreed to share their personal stories with hard to control seizures and the alternative therapies that they turn to in their journey to get better control of their seizures. But first, let me more formally introduce Dr. Bunch. Dr. Bunch is a neurologist specializing in the treatment of epilepsy in the Department of Neurology at Albany Medical Center. Dr. Bunch is also an assistant professor of neurology and joined Albany Med's Adult Comprehensive Epilepsy Program, which is one of just 6 programs in the state to be granted membership into the prestigious National Association of Epilepsy Centers. The program also holds the NAEC's highest designation, level 4, which is granted only to the best academic medical centers in the country. Dr. Bunch is fellowship trained in epilepsy at both Bethel Israel Deaconess and New York University School of Medicine, where she also received fellowship training in clinical neurophysiology and served as chief during her residency training. She interned in internal medicine at Hahnemann University Hospital, an affiliate of Drexel University College of Medicine in Philadelphia. She received her medical degree from Robert Wood Johnson Medical School, University of Medicine and Dentistry of New Jersey. In addition to treating patients with known or suspected new onset seizures, Dr. Bunch also treats adults for neurologic conditions, including headaches, tremors, movement disorders, and more. And she is also a member of our professional advisory board. So without further ado, I will turn it over to Dr. Bunch.
Thank you, Erica. Hi, everybody. I'm glad to be here today, speaking to everybody virtually. I'm going to be talking about drug-resistant epilepsy or hard to control seizures. So I'm going to start off by just saying I have no disclosures and review the outline of my talk. I'm going to start by talking about what is drug resistance and why does it matter, what goes along with that kind of diagnosis. How do we reduce risk when you have that condition? What are some medication strategies that we use, dietary therapies that are used, and surgical strategies that are used to treat it? So first off, let's talk about what is drug-resistant epilepsy. Well, it's hard to control seizures. Another term that's been used for it is intractable epilepsy. And there are a lot of seizure medicines out there on the market. I like to say the FDA has approved about 30 seizure drugs. But we really consider someone to have hard to control seizures after they have failed to have good seizure control after a trial of at least 2 medicines. So you really only need to fail 2 medicines to get labeled as having drug-resistant epilepsy. And I'll explain a little bit more about that in the next slide. One thing you need to know is that the medicines need to be appropriately chosen. So they need to be the correct medicines. And they need to be tried at appropriate doses, not just a tiny little dose and there are some side effects. That's not the same thing as really failing in medicine. So why do we pick 2 drugs? If there's 30 drugs, why don't you have to fail all of them? Well, we picked 2 drugs because basically this is a pie chart showing your likelihood of having seizure control, which essentially means 100% seizure freedom with a medication. So when someone is diagnosed with epilepsy and gets started on a medicine, that first medicine that they try has a 47% chance of controlling all the seizures. So about half of people will get seizure control on their first medicine. After that, if that first medicine doesn't work, then the second medicine still has a good chance of working, but only about 13% of everybody will get control 100% on that second drug. The numbers don't look good after that second drug. So a third drug only provides control for about 1% of our total population. And then a combination of drugs, only about 3% of people get good control. So then that leaves this big chunk of the pie, about a third or 36% of everybody who is labeled as drug resistant, meaning they're not getting good control from their seizure medicine. So if the first two drugs fail, we know that the odds of the third, fourth, fifth drug working for 100% seizure control are actually pretty low. So who tends to be drug resistant? Well, it's hard to predict right at the onset, but some risk factors are having a history of status epilepticus, which is a seizure that doesn't stop on its own. Having a greater number of big tonic-clonic seizures, otherwise known as convulsions, are a risk factor. Having had more seizures before starting medicine can be a risk. History of brain injury, a longer duration of epilepsy, and an earlier onset of epilepsy are also risk factors for drug resistance. Why? Why are some people just resistant to seizure medicine? Well, there are a lot of theories, but we don't really know why. One theory is that the brain learns to pump seizure medicines out of the brain. So this might be seen in someone who seems to respond to a medicine for a few weeks or months, and then they stop seeming to respond to it. Maybe the brain changes so that it learns to escape the effects of the drugs, so they're less effective. Another reason is that medications actually don't affect the underlying cause of seizures, they're just controlling the symptoms. So they're not fixing epilepsy, they're just masking the symptoms of the disease. Age may play a role in terms of drug resistance. We do see that older people are much more likely to be seizure-free than younger people. And why does drug resistance matter? Well, it really matters because we know that you're not likely to become seizure-free after the first few medicines have failed. So we want to think about other things. We want to evaluate you at an epilepsy center for many reasons. There are things called pseudo-resistance, which I'm going to get to in a few slides. And we want you to know about other options for seizure control. And out of everybody who's drug resistant, only a very small number are actually referred to comprehensive epilepsy centers for further evaluation. And we want to get that number up. One reason people are drug resistant is because they're actually being treated for the wrong diagnosis. They don't have epilepsy, or they don't have the type of epilepsy that someone thought they had. About 25% of people that are referred for video EEG monitoring in an epilepsy center actually don't have epilepsy. They have something else. So if someone doesn't have epilepsy, what are some other conditions that they might have that look like epilepsy and seizures? So one condition is called syncope. That's where you don't get enough blood flow going to your head and you pass out. When people pass out, they can shake all over and it can look just like a seizure. This can be caused from heart not beating correctly, an arrhythmia, or it can be caused by a drop in blood pressure, such as that's seen in vasovagal syncope, which is a really common condition, especially in young people, or a condition called dysautonomia, which is where the autonomic nervous system doesn't cause the blood pressure and heart rate to work together well. Metabolic problems like sugar or electrolyte problems can cause events that look like seizures and actually can cause seizures themselves. Migraines can sometimes cause seizure-like symptoms. Sleep disorders can cause daytime sleep attacks, or they can cause funny movements that can look like seizures. Movement disorders can cause tremors and shaking that look like seizures. And transient ischemic attacks or mini strokes are a form of vascular disease in the brain that can sometimes mimic seizures. I like to share this video. This is a series of German medical students were made to pass out on purpose. So these were healthy students. They basically squatted down and then stood up really fast. And what that does is it causes a drop of blood flow to the brain, causing syncope. And in this study, and I apologize for the poor video quality because it was done probably back in the 80s, it shows all the funny twitching and shaking and movements that can happen when somebody has a loss of blood flow going to the brain. And if you describe this to a doctor, they might think that it's a seizure, but it's not a seizure at all. So this young woman's healthy, has just had a loss of blood flow to the brain, so she falls down to the floor and she's shaking all over. And it looks a little bit different from a generalized seizure to me, but To people who aren't used to seeing seizures, you would just say they're shaking all over, looks like a seizure. There are some psychological conditions that can cause seizure-like events. The most significant one is now called functional neurological symptom disorder. It's also known as conversion disorder, and it can cause seizure-like events that are completely psychologically caused and need psychological treatment. People can also have panic attacks that can look and feel just like epileptic seizures. And the only way to tell the difference is with an EEG on the head at the time of the attack. There are behavioral conditions like intermittent explosive disorder, self-stimulating behaviors, breath-holding spells in children. All those can look like seizures. And in our older population, some forms of dementia are associated with spells of inattention that can look just like a seizure. Pseudo-resistance. Another cause is drugs, meaning the wrong medication for the type of seizures. For example, there are some medicines that can worsen epileptic myoclonus. So that's not medication failure, that's a choice of the wrong medicine. Some medicines don't treat all types of epilepsy. They're what we call narrow spectrum. So if the wrong drug is chosen, that patient's not going to respond, but there's a good reason for it. Sometimes the doses prescribed are too low or they're not being absorbed adequately. Maybe the medicine's wearing off too soon. And then drugs and alcohol can often be a trigger for seizures, even when the seizure syndrome can be controlled otherwise. And they also make it easier to forget medications. So that's not really drug resistant. That's just a problem that needs to be fixed. And we do see alcohol being a very common cause for breakthrough seizures. What are the consequences of drug resistance? Why is it so bad? Well, it's stressful having seizures uncontrolled, even though you're taking medicine. It can be very expensive. It can affect cognition, memory. There's a big psychosocial impact on work, driving ability, education. Families and friends can be affected. And then it can lead to death and injury. Uncontrolled seizures can lead to accidents, status epilepticus, increased risk of suicide, cardiac arrest, or a condition called SUDEP, which I'm going to explain soon. The overall deaths from epilepsy every year outnumber deaths from breast cancer. And it upsets me that breast cancer gets a lot more media attention than epilepsy. SUDEP. What is SUDEP? SUDEP is sudden unexpected death of someone with epilepsy. This person was otherwise healthy with no other cause for death suspected or found on autopsy. And it is the leading cause of death for people with uncontrolled seizures in the US. And it's always so surprising when it happens because it's unexpected. Annual deaths from sudden unexpected death in epilepsy overall are about 1 in 1,000 adults, so 1 in 1,000 per year. In children, the risk is lower, maybe 1 in 4,500 per year. But in our highest risk groups, which I'll get to the risk factors on the next slide, it can be as high as 1 in 100 per year. This picture in the bottom right is of Cameron Boyce, who was a Hollywood star, I guess, or a TV star, who suddenly died at the age of 20 from seizures, from some unexpected death in epilepsy. And he had only had about 5 seizures in his lifetime. It was so sudden and really heartbreaking to everyone who knew him. SUDEP is most common in those with uncontrolled tonic-clonic convulsive type seizures, especially having 3 or more per year really increases the risk. Frequent seizures otherwise also increase risk. Low levels of seizure medication can increase risk. It's seen more often in young adults or middle-aged adults, in those who have nocturnal seizures, in those who live alone or sleep alone, and alcohol may increase the risk of SUDEP as well. So when we have someone with drug-resistant epilepsy, we may shift our goals of care. When I first meet someone with a seizure disorder, and it's a new diagnosis, my goal is no seizures and no side effects of medicine. After some time, if we try, we may not be able to reach that goal. We may need to shift our goal a little bit. So for drug-resistant epilepsy, we try to reduce the seizure burden, reduce frequency, reduce the severity, reverse some of the post-ictal effects or the feelings that happen after a seizure, try to minimize the days lost due to each seizure, and really maximize the quality of life. Try to eliminate all the medication side effects that might be bothersome. Try to make the medicine regimen convenient, cost-effective, and try to address all the comorbidities that come with drug-resistant epilepsy. Quality of life and seizures are most linked to complete seizure freedom. But if we can't do that, then reducing medicine side effects and addressing depression, anxiety really helps. Reduction in seizure frequency does help too, but not as much as seizure freedom. Overall, what really helps people is developing a sense of control over their lives, because seizures can feel so unpredictable. So I mentioned before, addressing comorbidities is really important. So what are these comorbidities? So comorbidities in general are just things that go along with initial diagnosis. So not everybody has these things, but we look for them because they're super common in epilepsy. Depression, anxiety, substance abuse disorders, migraine, and sleep disorders. And all of these things are treatable. Depression is so common, but it's not okay. 20 to 60% of people with epilepsy also have depression. The suicide rate with people with epilepsy is 5 times the general population. That's about 11% of all the deaths in people with epilepsy. Depression and anxiety are treatable. There are a lot of treatments, and because it's a common condition, there are new treatments coming out all the time. So we often think about medications, but there are options other than medicine. There's therapy, individual therapy, group therapy. There are lifestyle changes, mind-body activities that can help, exercise can help, stimulators can sometimes help. There are so many therapies, I can't list them on the slide. It's a talk unto itself, but there are always things to try. In general, some guidance for people who live with epilepsy. Do take your medicines as prescribed, get adequate sleep, because sleep deprivation is a big trigger for a lot of people. And learn stress reduction skills, because it helps, not just with seizure frequency, it helps with managing that sense of control. Avoid alcohol and illegal drugs. Avoid triggers. You don't have to avoid every trigger known to man. You need to avoid the triggers that you are sensitive, your epilepsy is sensitive to. And avoid things that might cause extra risk for bodily harm if you were to have a seizure. There are some helpful tips online about epilepsy self-management to improve that sense of self-control. There's a Managing Epilepsy Well network that helps with treatment management, seizure management, learning to recognize and avoid triggers, and keeping track of seizures and medications. Safety precautions in general for people with new or uncontrolled seizures should avoid swimming or including hot tubs, anywhere with standing water, bathtubs, without somebody there watching them, because drowning is actually a leading cause of death. Life vests should be used for any deep water activities. Showers, not baths, are safer. Precautions for open heights, such as rock climbing, always wear a safety harness. No driving or operating heavy machinery, such as ATVs, snowmobiles, motorbikes. Those things are included with no driving. We have to think sometimes about safety for parents of young children or someone who might be watching a young child. Baby proofing is even more essential for anyone with epilepsy when they're watching young children. Wearing a helmet and avoiding traffic when using things with wheels. And then sudden unexpected death in epilepsy is more common at night, and people who have seizures at night are more likely to die. So consider monitoring, co-sleeping, baby monitors, or seizure alert devices, such as even there's heart rate detection monitors on a smartwatch that can alert somebody who even lives miles away. Technology can be very useful for monitoring and safety. There are a variety of devices out there. They're changing all the time. There are apps on phones, and like I mentioned, smartwatches. There are bed alarms that can detect movement in sleep. There are apps you can use on a smartphone to help remember to take medication or to do a bedtime routine ritual to calm down at night to get good sleep. There are ways to keep track of seizures or headaches using apps on a phone. There are a lot of ways that we can improve the quality of our lives by using technology. Avoiding triggers is important, but identifying your triggers is important too. You don't have to avoid everything, just the things that your epilepsy is sensitive to. So what are some medication goals? So I mentioned before, minimize cognitive side effects. So a lot of medicines tend to be kind of downers, depression, sedation, tired. So we want to keep an eye on that and eliminate medicines that are not working that are causing side effects. We have to look out for drug toxicity. It's easy to gather a combination of medicines when they don't seem to work for seizures. We just keep adding things on. But then the combinations of everything can add up and make someone more tired or loss of coordination. Very common side effects from every seizure medicine. Not all, but a lot of our medications do increase risk for osteoporosis, which is a condition of thin bones, putting people at risk for fractures later in life. So that's something we have to think about. There are a lot of medicines that may increase risk of a cardiac arrhythmia. We have to consider that. Phenytoin specifically, we have to monitor for dental care because it can cause gum problems leading to tooth loss. And it can also damage nerves with long-term use. So that's something we can monitor. If a patient may get pregnant, we always like to have them on the least amount of medicine that gives them the best possible seizure control. And motor seizures can be very dangerous in pregnancy, both for the mom and the baby. So we want to minimize those. Polypharmacy is the art of using more than one medication at a time, and it is very much an art. For the most part, all the drugs work effectively for seizures about the same. And there's no clear benefit for using more than 2 seizure medicines, but sometimes people just keep adding more and more medicine without taking anything away. Medicines can have drug interactions that we have to monitor for. And there are certain strategies with using seizure medicines that work with different mechanisms of action that may help reduce side effects. When we prescribe a seizure medicine, we always think about what we can treat with that medicine, not just seizures, but some seizure medicines help with mood. Some seizure medicines help with weight, either losing weight or gaining weight. Some help with migraines and other types of pain. So these are other things that we can take into account. There are always new seizure medicines coming out. This is just a sample of 5 medications that have come out in the past 5 years. So on average, there might be a new medicine coming out every 1 or 2 years. But as you can see here, sometimes the medicine isn't indicated for everybody. It's just a small portion of people with epilepsy. Medical marijuana is a broad topic because there's a lot of different things included here. So marijuana itself is a street drug, right? It's an herbal medication that has hundreds of chemicals in it. There are 2 main chemicals that go to the brain with some effects that we have well studied at this point. THC is the chemical that's more associated with the psychoactive properties of marijuana. CBD is cannabidiol, which doesn't have that property, but does seem to have a benefit for seizure control. Cannabidiol and THC can be available in New York State through a dispensary system. They're also available through the internet as supplements, and they can be bought over the counter in various places. The supplement industry is not well regulated. There was a study done of cannabidiol in some supplements that showed anywhere from 0 to 1,000% cannabidiol in the supplement based on what it had advertised. So it's a little bit risky using those. But the prescription cannabidiol, that's called Epidiolex, is highly regulated and FDA approved, only studied well enough for Dravet syndrome, Lennox-Gastaut syndrome, and seizures associated with tuberous sclerosis for FDA approval. But it's possible further indications may be approved by the FDA in the future. Just because it comes from an herbal source does not mean it doesn't have side effects or drug interactions. It very much does. And these need to be monitored. What are some other alternative kind of medications? Most dietary supplements otherwise are totally unproven for seizure control. The one exception is there are some rare syndromes where B6 can be helpful, but outside of those syndromes, B6 is not helpful for seizure control. There are some herbs that have been shown to cause improvement in seizures, at least in animal models. But those herbs cause the same, if not worse, side effects than all the medicines that we have on the market now. So there's a reason why they're not FDA approved as drugs at this point. Something that is important to think about is emergency medication use. So a lot of people do tend to cluster, and anyone can be at risk for having status epilepticus. Again, a seizure that doesn't stop on its own and needs an emergency medicine. So the emergency medications can be used to help prevent emergency room visits and admissions to the hospital. So they should be discussed. Traditionally, we've had rectal diazepam available for many years. That's been a reliable medication, not the most pleasant form of administration for most people. Fortunately, in the last couple of years, we now have 2 nasal spray options that are available for emergency medication use. And there also are oral dissolving pills for people who are clustering in a seizure or who are wearing up during a seizure to get a medicine put on inside of the mouth along the cheek. So these can really help in terms of cost and days of life lost due to seizures when used correctly. Dietary therapies can be an option for some people. They're not necessarily easy, like any diet. They're hard to follow and they take some commitment. The most classic of all these is the ketogenic diet, which has been around for millennia, really, but it's been well studied for at least 100 years now. The ketogenic diet is an extremely high fat with minimal carbohydrate intake. Calories and fluid are restricted, and there can be a really significant seizure control with some people. It's actually the therapy of choice for a small number of syndromes in children. Overall, about half of children have a greater than 50% seizure reduction at 1 year after starting the diet, and adults can have similar responses. So if you're talking about somebody with drug-resistant epilepsy, those are better odds at good seizure control than further medication trials. The problem with the ketogenic diet is that it's pretty hard. 90% of people stop the diet before 3 years are up because it's hard to maintain. It takes a lot of regulation, and there are some side effects that need to be monitored for. People can lose weight on it. There can be cholesterol problems. Constipation is a big issue and may need a lot of supplements to treat it. People can develop kidney stones, among other things. A little bit gentler, but probably a little less effective, is the modified ketogenic diet, which liberalizes carbohydrate intake to about 10 to 20 grams per day. Fluids and calories and protein can be, don't have to be restricted like they are in the ketogenic diet. And the data on this is about 47% of children had a greater than 50% seizure reduction. In adults, it seems a little bit less effective, maybe a 25% improvement overall. A diet that I like to recommend that I feel like is a very healthy diet for anyone to follow is the low glycemic index diet. What a glycemic index is it measures the degree that food raises the blood sugar level. And what this diet allows for is about 40 to 60 grams a day of the low glycemic index carbohydrates. And overall, mild improvements are seen. I do have a few patients who report good seizure control with it. It does take discipline too, but it's not nearly as restrictive as the ketogenic diet. You can see by this little graph at the bottom, things like whole grains are okay, but really high starchy foods, white breads, things like that are off. Surgical options. These are options for people with hard to control seizures, and they can be life-changing for many people. Brain resection is where you cut out where focal seizures start in the brain. So it's not an option for people with generalized seizures. It's only an option for people where seizures start in a small area. Corpus callosotomy and various stimulator therapies. And I'll discuss a little bit more about each of these. So people with focal or partial seizures who don't have good response to seizure medicines should be evaluated for resective surgery. Not everyone wants to consider brain surgery, but it's an option, and there are some people where it can be a cure. We always do a lot of testing before offering brain surgery because we need to know exactly where the seizures begin, and we want to make sure there aren't important functions like language, memory, strength, vision in that area that we want to remove of the brain. Sometimes we do what's called invasive intracranial EEG monitoring. That's where electrodes are placed underneath the skull in the brain to look where the seizures are starting before we actually cut out anything. Some patients are even able to stop taking medication and be seizure-free after surgery. A newer option for a select group of people is to have something called MRI-guided laser ablation. So instead of having an open surgery, a MRI is used to guide a catheter to perform laser ablation to a small area of the brain to destroy that brain tissue to stop it from starting seizures. Corpus callosotomy is a procedure used to help with seizures. Started about 80 years ago, and the corpus callosum is a structure in the center of the brain that connects the two halves of the brain. Cutting through that corpus callosum disconnects the two hemispheres enough to keep seizures smaller. It's most helpful usually children who are having what we call drop attacks or atonic seizures where they fall to the ground, because it slows the spread of the seizure and can stop that violent fall that can cause so many injuries. I've seen people with very significant improvement of their seizures from this procedure. Stimulator therapies, there are a variety out there now. So the vagus nerve stimulator has been out there for decades. What it entails is a day surgery, about 1 to 2 hours. A stimulator box is placed usually in the left side of the chest, and then a wire goes from that box to the nerve in the neck called the vagus nerve. And the vagus nerve normally sends mild calming impulses to the brain throughout the day. This stimulator increases that activity, which calms down the excitability of brain activity, leading to a slow reduction of seizures over time. Not everybody responds to it, and it's hard to predict who will respond, but about 7 years after implantation, there's about a 70% reduction in seizures. About 1 year after implantation, the response rate is probably only about 50%. It's now FDA approved for ages 4 and up. It's also FDA approved for depression. There is an option to use a magnet that can be swiped over the box when a patient's having a seizure that sometimes makes the seizures milder or less severe. And there's also a newer device that detects a rapid heart rate increase, which most seizures are associated with a rapid heart rate increase. And it can give a little extra stimulation response to that in case it's a seizure to try to make it milder. We don't know exactly how it works, but it does seem to help most people. Side effects include hoarse voice, throat discomfort, difficulty breathing, maybe a tingling sensation, and most of the side effects disappear over time. Hoarse voice can linger, but doesn't tend to bother people too much. So the response is seen very slowly. It doesn't do anything overnight. It can be very frustrating while you're waiting for it to take place and to take effect, and we slowly increase the settings over time. Seizure freedom rate is probably around the order of 10%, so not likely, but not unheard of. It can also improve mood and allow for medication reduction, but most people stay on medication. VNS has been proven to lower the use of healthcare resources, lower the occurrence of sudden unexpected death in epilepsy, and improve quality of life. Deep brain stimulation was approved in the US in 2018, a little bit earlier in Europe, and it was approved for focal epilepsy. The data on deep brain stimulation is that it reduces seizures by about 40% at 3 months after implantation. And the numbers, like all stimulator therapies, improve over time. So there was about a 75% reduction at 7 years after implantation. You can see by the picture, there's a box in the left chest, just like the vagus nerve stimulator, and a wire, but instead of going to the vagus nerve in the neck, The wire goes into the head, under the skull, and there are 2 electrodes implanted on either side to the thalamus, which is a deep structure in the center of the brain. And it's programmed over time to stimulate that thalamus, and that's been shown to reduce seizures. Responsive neurostimulation has been available since 2013. It's a very interesting device only for people with focal epilepsy from 1 or 2 locations, and you need to know where those locations are in the brain. The box is not in the chest, the box is actually in the skull, and it has electrodes that monitor the brain waves, and we program it to detect the patterns of seizures and treat the seizures directly with electrical stimulation. And we adjust it over time. And around 3 months after implant, there might be a 30% seizure reduction. 7 years after implant, about a 72% reduction in seizures. There are other benefits to this device. Cognitive effects have seen that are good, and also good mood effects have been seen. The surgery actually involves removing a portion of the skull for that box placement. So stimulator summary, all seem to help, but not everyone responds, and it's hard to predict sometimes. All show more benefit over time with an approximate 70% reduction in seizures 7 years after implantation. All the devices need their batteries replaced at some point. So if the device doesn't work, we usually leave it in and just don't replace the battery when it fades. So take home messages for everything. Always think about another opinion, see a different seizure specialist, or go to an epilepsy center if you haven't already tried one, because there are a lot of options and a lot of things to think about. Sometimes getting another opinion can help. Take medications as prescribed and talk to your doctor if there's a reason why you don't want to take them. Keep an open mind about trying something new, because even though the chances are low with each new medication, they're not zero. Think about safety and think about treating mood and other comorbidities, because they're treatable and they can really improve quality of life. And I'm happy to take any questions.
Thank you so much, Dr. Bunch. That was really wonderful. And I feel like I always learn something, even though I think I know, sort of a lot, I always learn something new. So thank you very much. And we actually did have one question come into the chat, sort of regarding nocturnal seizures. One of our attendees is wondering if you have knowledge about the, I might say this wrong, the SAMI system, the night camera.
I don't have any real personal information about it. I just know that in general, trying things like that, it's always a good idea for safety, but sometimes you do spend your money on things and they don't tend to work out that well because they don't tend to be covered by insurance all that much.
Okay. Are there any other questions for Dr. Bunch? And again, I welcome anyone to put questions in the chat, or if you would like to unmute and ask your question, feel free to raise your hand using the raise hand function, and I can invite you to unmute.